Welcome. My name is Laura Rowan, pelvic health occupational therapist and founder of Essential Pelvic Health, and I'm here with Carly Detterman. Please tell us what your background is.
Great. Thanks, Laura. Thanks for having me. I'm super excited to be here because we both kind of like to nerd out about this stuff. So that's what we'll do today. I am a midwife, so a certified nurse midwife, so trained as a nurse, and then I have extra training in midwifery. And I'm also a Menopause Society Certified Menopause Society Provider, which means that I did some extra training to become fluent in menopause care post my midwifery training.
Okay, and that's a great place to start because I think we've done a lot of workshops. We've been collaborating together. We hosted the M Factor screening, so we've the past few months gotten to know each other pretty well.
Yes.
And the Menopause Society is a way to get more training, right? To go a little bit deeper. And what I hear a lot in the research that I've been finding is that gynecologists, medical providers that haven't sought out that additional help aren't quite getting the whole picture to be able to support women in menopause.
Sure. And that all comes back to our training. Really, none of us were trained in menopause care. Only a very, very small amount of OBGYN providers, less than 10%, feel prepared to take care of people in the menopause transition because it just for so long was something that was ignored. I didn't really get but an hour. So really, unfortunately, there's not a ton of information in our training, and then we're working with providers who don't have training, and so everything kind of is falling through the cracks. Now we're all realizing that this is an important part of life and that there's kind of specific things we need to consider, and so more and more providers are getting this extra training, and it can be all sorts of providers, as you said, so not necessarily GYN providers, a lot of internal medicine folks, endocrinologists, urologists, things like that.
Yeah, and just being able to understand the more, and that's why we're doing this, the more that we as consumers and humans understand about our bodies and about this transition, the better that we can bring the information to the providers so they can kind of help connect the dots.
Yeah.
I think it's hard for any medical provider to take some information that is separated, because for myself, like I even remember when I was in high school, I had this like abdominal pain all summer. I would play basketball and like I'd get this like drawing pull. So the doctors were like, well, it must be an abdominal strain.
Right.
And then it just kept happening. And then finally, at the end of the summer, I said, and by the way, I've been having these fevers all summer.
Right.
And they're like, oh, let me check your urine. And I had a kidney infection.
Oh, wow.
And instead of feeling it in the back, I felt it in the front.
Yeah.
But because I didn't connect the dots to bring both of those pieces of information together, how could they really?
Yes.
So, the more we know, we can start to like do our little checklist and bring our symptoms together, right? Not just talk about our joint pain separately from our moods and emotions, separate from our heavy bleeding, or whatever it is that's going on, or our skin and our hair.
Right.
And then that will help them to be able to start to look at hormones, right? Start to have that little bulb go off. But also for providers to start to say, I really don't know a lot about this or how to provide care. So to start to either seek out that additional training or just make the referrals to the people like you who do.
Exactly. Yeah, the problem with Western medicine, there are a lot of good things about it, that's for sure, but a lot of, the biggest problem is that it's very fragmented. So, I train my GYN background, I deal with female body parts, and everybody has their niche, but really menopause is kind of a full system. I don't want to say problem, it's just a full system occurrence. So we really need to look holistically. And so when you're, going to your primary and saying that you don't feel well and you have joint pain, then they might send you to a rheumatologist who's just going to think about your joint pain. So you really need someone who can look at the whole picture. And that's just going to be someone who has some extra training in menopause care.
Awesome. And you just mentioned something that is really kind of key is, you don't want to consider it an issue or a problem,
Right.
a condition, an experience, and symptoms, right? So thinking about mindset of menopause, right? We hear a lot
Yeah.
of this like, oh my gosh, this thing is going to happen to us in more of a worry perspective.
Right.
What are like what are ways that we could start to change the script, and because we know that our mindset can kind of
Yes.
manifest a
Great
little bit of our
question.
experience.
Great
So
question.
yeah.
So yeah, that's a lot of what I do when I work with folks is work on mindset. So, I think it is wonderful that menopause has come to kind of our popular discussions, and that this life phase is getting more attention. What seems to be getting more attention is things that have quick sound bites, like all the downsides of menopause, like all the things that we're going to experience, which are uncomfortable when you experience them at first. But the way I like to think about it is that, perimenopause is challenging because there's so much changing, but after that, it's kind of this new life phase that I find to be really empowering. And what I always tell my clients is that, something is actually happening in our brains. We used to be driven by estrogen, which is the hormone that gets us to take care of people, to put, I mean, this is a gross generalization, but to put other people's needs before our own. And our brains are changing, so that's no longer what is like biologically driving our behavior. And so when that all falls away, we're more apt to take care of ourselves, to speak up for ourselves, to put ourselves first, to kind of, instead of looking for a mate or that sort of thing, to kind of just look for what we can do to help the greater good. And it's really a brain change that I personally am enjoying. I mean, you will hear people say that they really kind of give no Fs anymore, which is really true. And it's just a really empowering place to be. The other thing that I think is good about menopause is that you can kind of be trucking along in your 30s and 40s and, like feel reasonably well, maybe not taking super good care of yourself. And then menopause kind of puts a pause on that, so to speak, and you really have to kind of think about like what you want the next half or the next third of your life to look at, and really dial in the things that are going to, make you feel good. And also another thing that happens is that, during this life phase, we really have to slow down. Like I think in our culture, as people with kids, as people with busy jobs, we really like are conditioned that we can do it all and go, 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 go. When your body changes, you cannot do that anymore. And you really have to kind of figure out what's important and prioritize the things you can do and just let go of all the rest. So I personally, once I got through the chaos of perimenopause and figured out what was going on, this is my favorite life stage so far.
Okay.
It's been great.
An
So
endorsement.
do not despair. Do not despair.
Awesome.
Yeah.
Okay, so what brought you, because it sounds like you've had some personal experience. What
I have
brought you
had some personal
into this
experience,
work,
yeah.
into this focus
Yeah.
area?
So as a midwife, I've really always focused on kind of what our bodies do physiologically, and, supporting that in terms of, like I support physiologic labor, pregnancy, like we just let our body do its thing. We help our body if it needs a little help. And kind of that's how I thought that I was going to approach the menopausal transition. And what happened to me was that during COVID, I was 44 years old, and kind of my life was falling apart, and I thought it was just, I had 2 kids who were in puberty that I was homeschooling at home. I mean, you all can imagine what that was like. And I really thought it was just like the stress of that. But really, I was just really having a lot of health challenges that I couldn't figure out, going to a lot of different providers, listing all my symptoms, sending me to other providers, trying a lot of supportive things that did help, like acupuncture and things like that. But I just couldn't figure out what was going on. And one of my friends who's a midwife who's a bit older than me said to me, like, do you think maybe this could be perimenopause? And I was like, no, I know that it's not. I am young. Like, I don't know what you're talking about. This is what's happening. And then slowly I began to think about what she was saying, and I realized that that was what was going on. And knowing that I couldn't kind of sort that out, or any provider that I could went to could sort that out, made me realize, like, I need to really kind of learn more about this. So I'm pretty sure that for the past 15 years I had been practicing before, many people came into my office with this kind of list
Yeah.
of symptoms, and I was kind of like, I mean, I don't know, like, drink more water, like, so I had realized what a disservice I had been doing to my patients. And it's not like,
And that's a
yeah,
common thing I hear from a lot of the providers who have sought the additional education
right,
is they reflect back to the provider that they were before and can realize that maybe they hadn't quite helped their clients in
yeah,
the way that they would now. Yeah.
exactly. And you live, you learn, and like, you just move on from there. So,
I mean, with anything, I
yeah,
can think about
yeah,
my first clients. You
yeah,
gotta start somewhere, and
you
I'm like,
gotta
oh,
say,
I would love to
yeah.
go back and treat them again.
Yeah, yeah, yeah. So that's how I came to this work. So then I really just started doing extra training, and learning all about kind of the menopausal transition and what we can do, from my lens as a GYN provider to support that transition.
And I mean, it really, I'm discovering there is, just like pelvic health, it is a specialty area, but it's such a large umbrella. It encompasses so many smaller niches. There's so much. You can't know everything about it.
No.
And so, like gynecological care, menopause really is a specialty that has so much within it. I think it's hard to have like everybody to know how to care for these people without really specializing and going deeper, right?
Yes, yes, totally. I agree. And even then, I have, it's been interesting. I've been thinking a lot about just all the different ways that people can get support, be it using menopausal hormone therapy, acupuncture, seeing a naturopath, and all those things are like equally important. And I think people come to me, as someone who works like with menopausal hormone therapy from that lens, and they kind of are asking me all these questions about like what, from a naturopath perspective, like, what should I be doing? And I know the basics, but what I tell people is this is a time in your life when you need a lot of people on your team.
Yeah.
So if you need somebody who can like work within the medical model, and then you also need other supports, because it's not just one thing that's gonna get you there. So I do not know of like someone who I can recommend if you want to get like all your support from every angle from one provider, because that's just not the way things work. So you're going to find two, three, a couple of folks who are really going to support you: nutrition, pelvic health, just like from different angles. So that's the important thing to consider too, I think.
Yeah. And I mean, it's a whole body experience because there are hormone receptors all throughout the body, through the brain, through musculoskeletal, the genitourinary. And so we really need that team approach because we need all the modalities, right? And what
Exactly.
works for one person isn't going to necessarily work for the next person. And so being able to have that shared decision making and to be able to kind of follow the plan. Okay, that didn't work. Let's see what we can do next, right? So,
Yeah.
I mean, even with like, if you do go with hormone therapy, there are so many options there
Yes.
and so much almost like tinkering, it sounds like, to
Exactly.
find the right.
Yeah, a lot of trial and error. And I think we're kind of prone to want like a quick fix, just like make this go away, make me feel better. Like, I just want to feel better. I've been there. But it's not one thing that's going to make you feel better. It's not just hormone therapy isn't a magic pill. Like, you need to really layer a lot of things, and it's doesn't happen quickly. So it's frustrating for folks, but actually in the end, then you've really put together like a kind of plan for your health for really the rest of your life, and kind of, you just kind of play with it from there. But once you have that foundation there, you're going to feel, pretty good for the rest, however long
Yes.
you stick to it. Yeah.
Yes. Okay, so we got lots of great questions here. Like briefly, because I want to get to all of these because they're
Okay.
really good.
All right. We're going to
But
keep it brief.
briefly, what's happening to our hormones in menopause, perimenopause?
Okay. So the thing to know about, people will often come to me and say, like, my hormones are I just feel like my hormones are out of balance. And if we kind of determined you're in perimenopause based on your symptoms, what your periods are doing, and your age has something to do with it too, then we can kind of know that you're in perimenopause. And yes, your hormones are out of balance. I don't, our hormones are always shifting. Your hormones are shifting because that's what defines this phase. So yes, that is true. And so in perimenopause, it's really the worst. Progesterone's getting lower. Estrogen is all over the place. So that's what's causing us to feel so chaotic. And that is kind of like a normal physiologic fact of what's happening then. And then in menopause, our ovaries stop making estrogen and progesterone. Our testosterone is slowly lowering from our 20s. And so, like, really, our body is making no more of those sex hormones. And that is normal. So you feel different because of this, but it's not like a pathological thing that's going on. It's just a process of hormone shifting. So it's not that you really need to like balance your hormones or like get yourself back in line. You just need to kind of know what's happening and then work with it to kind of optimize your experience.
Yeah, and I think that's why we saw a shift in the language from hormone replacement therapy
Right.
to menopause hormone therapy.
Exactly.
So
Yeah.
we still use replacement therapy when we are younger and it's not related to menopause.
Right.
But related to menopause, we're not trying to replace anything because that is the direction we're going in, but trying to give our bodies what it needs to not feel symptomatic.
Yes.
Right?
Exactly. Exactly.
Okay. And what's happening to our brains?
Oh, our brains. I kind of talked about this before when I was talking about kind of that shift that our brains are going through. So our brains are remodeling, actually, like synapses are being trimmed, new synapses are being formed to bring us from that like nurturing being to that kind of wise woman being. And that feels hard because our word finding is suffering. Just kind of that brain fog that people describe, like that is just like, am I going to feel like this forever? I feel like I can't function. And that's just our brain changing. And you do go back to baseline. And a fun fact I always like to throw in there is that even at our lowest, when they do testing of brain function, even at our lowest in perimenopause, when our brains are chaotic, we're still at a higher rate of brain functioning than the average male. So even though we feel terrible, we're not so bad, and it's going to get better. So that gets better. Like that terrible feeling, this too shall pass, and it's just our brains kind of letting go of that, changing into that wise woman. So that I think is comforting to people.
Yeah.
Yeah.
And because I think the fear is, oh my God, I'm developing dementia.
Exactly.
Right?
And it does feel like that for many people. Just kind of, and the other thing to know is if you have kind of underlying attention stuff, like maybe you are prone to a little bit of ADHD, things like that, that gets super exacerbated in perimenopause. So many women who are able to kind of keep their symptoms under control by just being super organized and over functioning, they just can't do it anymore in perimenopause. So some people need some support from that direction too. But it gets better.
Yes.
Yeah.
And so, thinking about, okay, I'm starting to have this brain fog and mood changes, right? So the cognitive, executive functioning, those kind of deficits, but also the mood and the emotions. So, we hear, okay, we have these things, and then we hear, like, say, on like celebrities promoting
Right.
menopause
Yeah.
hormone therapy.
Uh-huh.
But the research and what the Menopause Society is telling us is different. So, as far as like if we were experiencing these things and we want to address it, what would you recommend? Do you recommend hormone therapy? Do you recommend other things?
Yeah, that's such an individualized question. And so when we talk about hormone therapy, it is, we have great research that it's approved for certain things, like that it does well with certain things, like hot flashes, night sweats. We call those vasomotor symptoms. Genitourinary urinary syndrome of menopause, which is kind of that, de-estrogenization of your pelvis, and bone protection. So we know with certainty that it impacts your kind of the way that your bones, your bone health in menopause. And also, obviously, we use it if you go into menopause very early, like before 40, then you absolutely, for health reasons, should be in hormone replacement therapy. After that, it's kind of a risk-based risk-benefit discussion. I mean, it always is with your provider. So there are estrogen receptors in our brain. For many people, trying menopausal hormone therapy absolutely helps with their brain fog. Do you need to go on menopausal hormone therapy or else you're going to get dementia? We don't have any data to say that that's a thing, right? So if you are a person who really is not very symptomatic and don't feel like, I think the cultural zeitgeist right now is like, this is kind of what's going to protect everything from going down the path of aging, and so therefore I should absolutely be on menopausal hormone therapy. And we just don't have enough data to know that to be true. And so it's just really individualized. Once a person looks at the whole picture with an informed provider, and decides, is this right for me or not? We know anecdotally, and there is some data, but not enough to say that it's, definitively true, that people's brains do feel better. I know I can say for myself, it was like a night and day with the brain fog. But we just, we have to be careful about how we talk about it.
Yeah.
Yeah.
And so just like you said, we have research for certain things. We don't quite have the research to back other things, but that doesn't mean anecdotally we haven't
Right.
seen it help.
Yeah.
Right. So but I think the overall message is, no, you don't have to start taking hormone therapy if you don't have symptoms, just to prevent or protect you.
Exactly.
Yeah.
Yes. And certainly, if someone comes to me and their only symptom is brain fog and they are like, I am at my wit's end, I would like to try some estrogen. Sure. If you're a candidate for estrogen, which is most healthy people within 10 years of menopause, you can try it. And, either at the appropriate dose for the right amount of time that you've tried it, it either will work or it won't, and then you'll have your answer. Yeah. So,
Because that's the thing
yeah.
too. It's like, try it, and if it doesn't work, then stop taking it.
Yeah,
Or if you
exactly.
have adverse
Yeah.
effects, you stop
Stop
taking it.
taking
It's
it,
not
yeah.
like you've gone in a direction that you
Yeah.
can't
Yeah. It's just,
undo.
yeah. And make sure that, if you, make sure that you are working with someone who can kind of, if you're having this side effect, most side effects, we can, just tweak things. If it's not working at all, then it might be the root or the amount. So doing some tweaking, if you're feeling like it might be the right answer, but it's not quite right yet, just working with someone who can help you do that tinkering is important.
Thinking about hormone therapy that's like FDA approved, versus bioidenticals. So we have
Yeah.
this language here,
Yes.
and I know it gets so confusing when bioidenticals are spoken about as a superior, safer method of getting hormones over, say, synthetic
Yes.
hormones.
Yes.
Can you talk a little bit about that?
Yes, this is so confusing. And to be honest, I feel like I just maybe like 6 months into my prescribing was finally like, oh, I understand what's happening here. And the way I figured it out in my brain was that bioidentical doesn't really mean anything. It's a marketing term. And what it came from was that we had, a study in the early 2000s that made us all scared of hormone therapy. That's why none of us know how to work with it or prescribe it. And that's why we kind of think things like, oh, it's going to give me heart disease and cancer. So anyway, that happened. And then women, a whole generation of women were taken off their hormone therapy. Many people felt terrible about that. And there was really then kind of menopause treatment went away. And so industry is smart. Entrepreneurs are smart. They kind of came up with a way like to say that, okay, if we use compounded hormone therapy that's bioidentical, meaning the same thing as the estrogen and progesterone in your body, that's safer. And so a whole compounding industry sprung up, some other industries like the pellet industry, things like that sprung up. That was kind of a solution to kind of women being left in the dark. And like we all know, it's under-researched. Women's issues are under-researched. And so we kind of understand how that all happened when we put it in a historical perspective. So what we know, though, is that there are many different kinds of estrogen. Some of them are the same chemical composition as what's in our body, and those are like estradiol and prometrium, which is what we generally start with when we're putting people on menopausal hormone therapy. And those things have many FDA-approved formulations, patches, oral. There are rings you can put in your vagina. There are creams. These are things that are all formulated the way that we formulate any medication. They go through rigorous trials. Your insurance will cover them. And they are, like I said, the same chemical composition as what's in your body. And that is kind of what we can call bioidentical. So in the compounded formulas, what happens is they take this same thing and like mash it up and put it in a cream or some sort of delivery system in a compounding pharmacy, and then you get your hormones that way. And that's another way to get them. Usually insurance doesn't cover it. It can be variable what you're getting every dose, different compounding pharmacies, different pharmacists. I mean, it's like making something in your kitchen, which is not bad, but it's just not always the same thing. And somehow in our way of talking about this, people think that compounded is going to be safer, but really it's less regulated and not safer, and actually the same kind of thing that you can get if you're getting an FDA-approved hormone therapy, which many are body identical. You can also use synthetic estrogens and progesterones in menopausal hormone therapy, and there's many reasons why I do use them. Some people don't have a good reaction to some of the like the prometrium. It can make you a little bloated, for some people, not everyone, people with that progesterone sensitivity, and so then we might switch to a synthetic. And some people, just for whatever reason want to do something different. So there's not one is not safer than the other. It just all depends on kind of your personal medical history and how you feel.
Okay.
It's a long answer, but
No,
it's complicated.
It needs a long answer because
Yeah.
it's confusing. It's complicated. And I think so a lot of times, like the Menopause Society is very conservative, and a lot of researchers and doctors that I follow are very conservative, and so they're going to be like, don't go with the bioidenticals. They're not FDA approved.
Yeah.
Don't go with compounding pharmacies. They're not as regulated. But then I also, kind of just being able to have an open mind and speaking more, the FDA approved are going to be covered by insurance. So
Yeah.
start there,
Start there.
right?
Start
And
there.
then what's nice
Yeah.
is you've got bioidenticals available to you if that doesn't work, or
Right,
if
the
you
compounded,
need
yeah.
like because their prescriptions are pretty set, right? There's not a lot of flexibility within the prescriptions. So if you need a different dose and you need, or if there's something that you're allergic to in that,
Yeah.
the bioidenticals can be
Yeah.
very helpful,
Yeah.
but also understanding that you don't need to skip that first step
Right.
and go right to bioidenticals and spend extra money.
Yeah.
Like see if that helps first.
Exactly. So I do use compounding pharmacies for exactly the same reasons that you said. Like if someone has an allergy to something in a commercially available product, sometimes it's just for what their specific situation, it's better for the dose or the delivery system to do it in a compounded, and that's fine. It's a lot more expensive usually, and some people don't mind, but yeah, there's nothing that says that those compounded things are any safer than FDA approved options. So that's just important to know.
And I think correct me if I'm wrong, I think some of the progestin is formulated with peanut oil.
Yeah, so the prometrium,
Okay.
so that's the body. We don't have a good term for bioidentical, the kind that means that it's the same formulation as what's made in your body. So the prometrium is the same kind of chemical composition as our progesterone that's made in our body, but that is made in a factory that has peanuts. So if you're allergic to peanuts, you cannot take the FDA approved version. You could use a synthetic form of progesterone, or you can get something, they can compound the oral. It's important for endometrial protection. You always need to take the body identical or orally, because it does not absorb through your skin. So that's just important to know. The synthetics do absorb through your skin, through like the patch or whatever, but if you're just getting your progesterone through your skin and you have a uterus, that is not good. It's a risk for endometrial cancer.
And
Yeah.
so your options there could be oral or like an IUD or
Yep,
vaginal.
oral IUD. There are some patches that have synthetic progesterone in them, and those molecules are smaller, so they'll go through your skin.
Okay.
So there's lots of options. Yeah.
And so tell us a little bit about testosterone.
Yeah, so testosterone, I think, is something that is also entering kind of our cultural conversation about menopause, which I think is great, because it means that we're also talking about sex and libido and sexual satisfaction for women, which has not been talked about really much at all. So I love all of that. And testosterone, what we know about testosterone is that our bodies just kind of naturally, normally, both men's and women's, they make, a lot of testosterone at puberty, and then it gradually goes down. And testosterone does a lot of things in our body, including impacting libido. And so we do have plenty of data to show that for some people where libido is not a relationship problem or there's so many, libido is so complicated, right?
Yes.
So if all those other things have really been worked on, kind of mindset, relationship, just how we feel about ourselves, like our own, like chaos in our life, if we're really,
Pain.
yeah,
Any other pain issues?
definitely
'Cause,
pain. Yeah.
Emily Nagoski makes a great point
Yeah.
in her book, Come As You Are. It's not a problem. It is normal to not like sex
Exactly,
that
if
you
it
don't
hurts.
like,
Yeah,
and especially
yeah,
if it hurts.
yeah,
Your
yeah. Or
body
even
is
like,
going to protect yourself. And
having sex that's really been not satisfying your whole life, and you just kind of put up with it because that's what you thought you should do. When your brain changes, you're like, yeah, I'm not going to do that anymore. And so if that's why your libido isn't the same as it was, then those are things to work on. So we work on all those things. If I work with folks, I do a lot of sexual wellness stuff. We work on all those things. So you get all that stuff down, and then you can consider, what I tell people is, you could just do testosterone, but for many people, just doing some estrogen and progesterone is enough to kind of to influence libido. If you want to try testosterone, that's great. The challenge with testosterone is that there's no FDA approved delivery system for women. Women, the kind of regular dose is about 1/10 of the male dose. So we just have to get super creative, and it's just a whole long rigmarole. You get little packets or kind of tubes, and you use 1/10 of it. It's just kind of a pain in the neck. It needs more monitoring in terms of lab work, because you don't want to overdose yourself and have like those like male symptoms like hair growth. But for many people, it does actually really help their libido. And that's kind of what we have evidence for. Again, it's another one of those anecdotal things that many people say, like they feel more like themselves when they take testosterone. Like, we don't have studies. We've talked about this before. We don't have studies about that, but how do you do a study about, do you feel more like yourself? Some people feel like it really helps them with muscle retention, which makes sense with what we know about testosterone. So So that's another thing where we have like enough data to say that yes, it helps with libido, not for everybody. And what I say is if you tried this for like 6 months and it's not helping, like it's probably not going to help you. And I do know, many people take it and say like, I feel more like myself. Like I'm noticing like just like my workouts are a little more effective in the gym. So again, it's kind of like a really risk-benefit discussion with a provider. And it's not a miracle, but for some people it's really helpful.
Okay. And what are your thoughts on, so kind of speaking to, yes, it's FDA approved for libido. So we've had some good evidence there. We're also noticing anecdotally some of the mood and feeling like myself and some of the musculoskeletal syndrome of menopause. So, when the tendons and the muscles
Yeah.
and the joint aches and those kinds of things. So I'm really, interested to see as research comes along. Hopefully, we'll start to get a little bit more connection in that
Yeah,
area.
yeah. I think hopefully that people are going to focus on that a little more in their research. I know I was on a webinar recently where there's some exciting new research happening in that area. So hopefully more to come.
Yes.
Yes.
And so, what are your thoughts on? So, I was speaking to someone, and they said during like this perimenopause, chaotic, like ebbs and flows of estrogen dominance and progesterone depletion and fluctuations, that taking estrogen and progestin may be hard during that time period, but testosterone would be their first frontline measure.
Yeah.
What are your thoughts there?
Yeah, so I think it's just so individualized, and usually I talk to people and kind of see where they are in that transition. What are their periods doing, and kind of like how chaotic is it, and what exact symptoms are they having? If they're having terrible night sweats and their periods are kind of on their way out, then I know that adding some estrogen isn't going to like make them have crazy bleeding or like make them have those like high estrogen signs. The other thing that is, sometimes people use just the progesterone because that if people are feeling anxious
Yeah.
or if they're feeling like really sleep is kind of their main issue, then progesterone works on the GABA receptors, the prometrium, and that can kind of just give some people some chill. So what I normally do is I just do a huge history and ask them about how they felt postpartum, because we know that's
Yes.
a hormonally shifting time, how they felt pregnant, just kind of getting some ideas. What's their PMS was like, what was puberty like for you? And then you can kind of get an idea of how hormones work for that specific person. And I like to just kind of in perimenopause, do one thing at a time. And then you can kind of see like, are you getting bad side effects from this? And there's a lot more tweaking in perimenopause. That's true. And I don't think there's one right answer. So certainly I have people who are like, I just want the testosterone. Like, that's just what I want to do. And I'm like, well, let's try it.
Okay.
Yeah. And then like, let's see,
Yeah.
come back in a month, 6 weeks, like really 2 months at the minimum is kind of what you need to kind of see how something's going to work. So it's just like a different thing for everybody.
Okay. And I'm
Yeah.
glad that you mentioned the postpartum comparison. That's how I got into all of this. I was doing a presentation for pelvic health and postpartum, and kind of wrapping up the conference with postpartum into perimenopause. So the overlap of symptoms in this changing hormonal transition
Yes.
for both of them, and also a lot of women having babies later where that postpartum
Yes.
actually overlaps with perimenopause.
Yeah.
So being able to
Very
understand
common.
that, and also take the information of what we experience during pregnancy and what we experience during postpartum can be a little bit of a window into our future, so we can start to make those like lifestyle, nutrition, exercise changes to mitigate some of the stuff.
Yep.
And really,
So
especially
true.
cardiovascular stuff. If we had any hypertension in pregnancy, looking at what that potentially might be predicting for menopause and just normal aging.
Yep. Yeah, very true. Yeah. Yeah, the pregnancy is kind of just a good window of what's to come.
Yeah,
Yeah.
and
Yeah.
also understanding your genetic history, right? So I know I had to kind of like do a little pulling to
Yes.
get that information.
Yeah.
Some families are very open, some families are more private, which
Yeah.
there's no right or wrong. But
Yeah.
that can really give you a lot of good information. And when you start your period, because it's kind of like you have your eggs.
Yeah,
If you
exactly.
start later, like a later start of menstruation,
Yeah.
then potentially your menopause is going to be later. Or if you start earlier, or
Yeah.
if you have babies and you don't have
Yeah. Yeah,
the
so many
periods for periods,
factors.
yeah.
Yeah, it is good to, I do usually ask people, like if they're just trying to figure out like how much longer do I have to do this? Like, can you ask your mom, when she went through menopause? And then can you ask, do you have sisters? I mean, there's not like an exact correlation, but it's just another thing that we can use to kind of figure things out.
Yeah, another layer. And then is this accurate? So like if you've skipped a couple months of your period in that perimenopause phase, that you can start to look at maybe within another 2 to 3 years, potentially menopause will be approaching?
Yeah, I hate to. It's like when people ask me, like, how long is my labor going to be?
Yeah,
Like when they're in
yeah.
labor, I'm like, I never make any predictions.
Yeah.
But once what I can say for certain is in the beginning of perimenopause, usually people have more frequent periods or heavier bleeding,
Okay.
and then it starts to space out. So and some people just have periods regularly and then never get a period again, right?
Yeah.
But and then if you kind of are in the heavier, then that might be a little longer. If you're in the lighter, then that might be a little closer. But who knows, right? Yeah.
Cool.
Yeah.
What about, so going back to testosterone and pellets. So is testosterone the only option to get pellets, or do they do pellets for all the different hormones?
So I know really not much about pellets. I do know you can get your estrogen from pellets, and testosterone.
That's true, because with
Yes.
estrogen,
Yeah.
if you get the pellets, you can't remove them.
Right.
So if you do encounter breast cancer, say, and you have had pellets
Yeah.
placed, you can't take that away.
Yes. So a pellet is just like a little, this is what I do know. It's a little small delivery system that gets placed under your skin, kind of with like implanted basically in your skin. And over time, I think it's like I'm talking about something I don't know much about, but in 3 months, kind of it time releases medication. And so what can happen, so I also know that the people that I see who are taking pellets are the people who it's not working for. So, I haven't done a bunch of like data review on pellets. What I can say is that the Menopause Society does not endorse the use of pellets because they are not really regulated. We don't have a lot of data. And because what happens is when they go in, oftentimes people will have big surges and then kind of peter out. And also when I see people, it's the people who don't feel well. And so normally what I see is they have super high testosterone and they're having symptoms of super high testosterone, which can be like hair loss and hair growth and things like that. And then they have an estrogen level that's not optimized. So look too low, and they're kind of having estrogen symptoms.
Okay.
So that's what I see. Like, I feel like I can't really speak, like, I can't speak to like exactly what the data says or anything like that, but I do, when people see me and they're not feeling well, what we'll do is get their levels just to see where they're at. And normally what I find is a very high testosterone and an estrogen that's like not in the therapeutic range. And so then we can transition them off. That's what I do. But I mean, I think, you got to kind of think about who makes money from things. And that can kind of inform, like, if a provider's making money off of doing something, then, I don't, yeah.
Similar
Yeah.
with supplements,
Yeah,
right?
exactly.
So really kind of looking to see who you're getting information from and what profit they're making from
Exactly.
their marketing.
Yeah. Yeah.
And I think with the pellets, so one, if it's not working for you, you can't remove them.
Yeah.
Two, it doesn't. It sounds like it doesn't have a good even distribution of the
Yes.
dose, so it
Yes.
higher in the beginning
Exactly.
and then drops down. For testosterone, if you were to prescribe testosterone, what method
Yeah.
do you tend to go to
Yeah.
for?
So this is what I was saying is there's no FDA approved delivery method, and probably never, people aren't going to make them. So I usually say there's like two ways to do it. You can use the male delivery method, which is for men. They can, they're prescribed Testim gel, which usually comes in like a ketchup packet, and they put the whole packet on. For a female, they put 1/10 of the packet on. So that's about the size of a pea. And so what I tell people is to just write the date on the packet, and then make it last 10 days. For some people, that's too much. And so then they know that their optimal dose is to make a packet last 15 days, which is not super scientific, but it's what we got. No one's ever going to fund, a drug company's not going to make a female testosterone delivery system. There's no money in that, right? So we have to get creative. The nice thing about that is you can, with a good RX coupons, buy yourself a year supply of testosterone for $150. And this is a case where someone is, some people I work with are just like, I am type A, like I need a measurement. You can actually put it in a syringe, and I show people how to do that, and then they can measure it out. And for people who want something different, this is a time where I do use compounding, because they can compound in a cream, the exact amount of testosterone that person wants. So I do use that quite a bit. You can use, males also use injectable testosterone, but that, like, not many people want to give themselves a shot. And usually that's for women a once a week thing. And that just, like I said, it'll give you a high spike and then a low. I like things that, you can get kind of once a day, because then it just keeps your levels steady.
And what about, so I had a friend who was recommended to start testosterone, and they were offered oral or the cream.
Interesting.
And she was concerned about the cream because she works with kids. So she was worried that
Yeah,
it would,
that's
because
a
that
great
can be
question.
like your
Yeah.
absorption rate
Yeah.
can be variable
Yeah.
depending on where you put it
Sure.
on your skin or
Yeah.
how you absorb things. So is oral an option?
Yeah, I don't do much oral because it goes through, it has to process through your liver,
Yeah.
and it can be kind of hard on your liver. I mean, all the data we have on oral is in men, and obviously they're taking a much higher dose. So I just don't really do that because of that liver, kind of the impact it can have on your liver. The thing to know about, kind of, it's good to kind of think about, like, who else is this going to come in contact with?
Yeah.
So obviously putting it, if you have smaller children, that might, do something with it. Then you want to put it somewhere where they can't get into your testosterone cream. Yeah. But it absorbs, especially the gel. It's in like an alcohol-based, the one that you get at the pharmacy. So what I tell people is to put it by your deodorant. If you shower in the morning, take a shower, put on your deodorant, put it on the inside of your thigh,
Okay.
or like on your butt or somewhere that's going to be covered with clothing. Let it dry, and then once it's dried, which happens in a couple minutes, it's really absorbed, and then you're putting clothes on top of it, so you don't really have to worry about other people.
And then if you just
your
wash your hands
Yeah.
or wear
Yeah.
gloves if you're really
Yeah.
concerned about it.
Yeah.
Okay.
Yeah.
Cool.
Yeah, wash your hands. Yeah, it's a little scary. Same with the estrogen creams too. People always ask me that, but you just put it kind of somewhere and cover it up.
Okay. So let's see. We talked about testosterone. We talked about libido. So what about, and again, so you mentioned the Women's Health Initiative earlier, that study that kind of like, we went from everyone take hormones,
Yes.
this will give you the fountain of youth, to just a halt. Everybody was scared to be on it. Doctors still are afraid and misinformed to prescribe it because they're afraid that it's going to cause breast cancer and stroke, right? So tell us. I think we've gotten the message out, especially the M Factor, the PBS
Yeah,
documentary. I think that did a really good job at starting to bring awareness around that,
I
right?
agree.
So
Yeah,
just
yeah.
a quick.
I'll do a quick summary. The thing that I've noticed actually since the M Factor and just since people are becoming more educated is I used to really have to do a lot of back teaching about the safety and efficacy, and now people are coming in and being like, I've heard all about that. I know it's safe. I want it. But just just to review, is that in the early 2000s, there was a study called the Women's Health Initiative, which was actually, we got a lot of good information from that study. So I don't want to say like it was a bad study or like, faulty or anything like that. We actually got a lot of information from it that we still use today. But it was designed to see if menopausal hormone therapy has an impact on long-term health. And the people that they enrolled were older. Some of them weren't having any menopausal symptoms. And so just kind of, that's something to know. And then they started, aggregating all the data and like kind of looking at things. And it looked like menopausal hormone therapy was causing an increased cardiovascular risk and also an increased risk in breast cancer. And that they had a press conference where they said that, and the media got a hold of it. And we know what happens when the media gets a hold of something. That kind of got put out into the cultural conversation and never went away for 20 years. Since then, we've done more research and also just like re-looked at that data and realized that the people who were having cardiovascular concerns were older, they were not within 10 years of menopause, they already had cardiovascular risk factors that were significant. And also the breast cancer thing was just when there were different arms. And the people in the estrogen only arm actually didn't have an increased risk of breast cancer. In fact, it was a slightly decreased. And also when they were taking menopausal hormone therapy, if they were diagnosed with breast cancer, they actually did better. Their all-cause mortality was less. The people who had a slight increase of breast cancer were people who were taking some progesterone. That was a synthetic progesterone. And they had their increased risk was the equivalent of having like a couple of glasses of wine every night. So it's a very small risk and something that many people are kind of doing unknowingly. The same risk as being obese, so it's like kind of like we have to right size the risk. So the progesterone is really what carried the breast cancer risk. And it was that, this is kind of why we all think, don't do the synthetic, it's terrible. It was the synthetic progesterone, which we don't use a ton. I mean, I still do use it and counsel people because it does work great for some people. But we have some data to show that the progesterone we mostly use, which is that prometrium, the micronized progesterone, actually doesn't have a ton of risk. And what we know now is that for cardiovascular benefit, if we take it within 10 years of menopause and especially below the age of 60, that it actually improves our cardiovascular health. So kind of a complete 180. And, I think people are always like, well, how do we know the pendulum is not going to swing the other way? Like, so that's when I say like, I think now kind of we're talking in the last like 6 months, kind of, it's like kind of in our kind of conversation, like, you have to do this or you're, something bad is going to happen to you. Like it is preventative. And it does help, but it's not going to like kind of, you got to do all the other things too,
Yeah.
So.
Yeah. And I look at it, especially, if, we know like the nutrition and the exercise
Right.
and the sleep and all of these things can really help improve how we feel. But if we are so depleted or chaotic, we can't do those things.
Right.
The hormone therapy can really help get us to a place to then not take over and not do those things, but to
Right.
be able to then implement those
Exactly.
things, right?
Yeah, if you're up all night, if you're,
Yeah.
not sleeping because you're having hot flashes, if you have like joint pain that's so bad that, it's hard to exercise, things like that, that's when I really kind of, that's when it's super helpful.
Yeah, and the bone density.
Exactly.
is very much something that estrogen is very protective of.
Yeah.
So being able to just even understand where your risk factors are there, you know.
Yeah. Yeah. If you have risk factors for osteoporosis, white race, a lower weight, or BMI, like up, I don't know how they come up with this number, but it's like under 128 pounds. You've lived there for most of your life. This is another good place where it's really good to know your family history. So does your mom have osteoporosis? Things like that. Then that is a time where you might want to consider, taking some estrogen for bone protection, because we really do have a ton of data that it helps. And if you have already been diagnosed with it, definitely it can help with that as well.
Okay. Tell us a little bit. So a question came up in the Menopause Positivity Facebook group, and it was kind of crickets out there. So I was like,
Yeah.
oh, what? And I've kind of heard like some people touch on maybe progestin can help with hair thinning, or the progesterone depletion may contribute to that.
Yeah.
So let's talk about hair thinning.
Yes. Okay. This is a big thing people ask me. And
Yeah.
this is what's funny is that, as a person with a GYN background, like hair is a dermatology area, right? But of course I've had enough people in my office that I'm like, I got to figure this out. And so what we know is that it is 50% of women are going to experience some hair thinning during the menopausal transition. And that's kind of like a normal thing that's happening. Okay, so we get to decide what we're going to make of that. Either we're going to kind of look in the mirror and have our mindset of like, this is just part of aging. I'm going to get a different hairstyle. I'm going to just like accept this as part of my aging body.
Because sometimes it can also just be coarser hair or curly hair. Like I've
Yes,
heard just
thinner
all
hair, like
different
yeah,
yeah,
and yeah.
changes.
And if that's not how you want to approach it, that's also totally fine. And you can know that what estrogen does, I haven't heard anything about the progesterone, so I can't speak to that. But what I do know is what estrogen does is prolongs the hair growth phase, so hair falls out less when you have estrogen.
Okay.
And so that's why it makes sense. So first and foremost, if you're noticing a lot of hair loss, you want to talk to a provider about it and just check all the other things that could be causing hair loss. Do you have a thyroid problem? Are you anemic? Think about kind of what's been going on. If you have a stressful event like postpartum, hair loss is a thing. If your mom just died, or good stress, like you just bought a house, or you just got married, like that can cause a temporary hair loss that will get fixed. So you're going to rule out all the things it could be. If you're having patches of hair, that could be a dermatological problem. So you'll really want somebody to look at your scalp. And if you kind of ruled out all of those things and you're just kind of in that perimenopause transition, menopause, and you're just noticing that when you look in the mirror, your part is thinner and just like there's just sparser hair, so like diffuse hair loss, that's probably hormonal. And do we have data to say that taking estrogen improves people's hair growth? No, like you would never say like, I'm going to go, my only problem is hair loss. Give me some estrogen. Do I have people who come and say to me that now that I'm on this, like my hair is different? Sure. Do I have people who tell me I'm not noticing any difference? Yes, that's also true. So it's menopausal hormone therapy is not a solution, but we do know that estrogen plays a factor. So I do believe people when they say that it's helping them. So what, if this is bothering us, like then we got to figure out what does help. So there is some data to show that some of the supplements do help. So specifically like the ones with like some biotin in them. Most of the research done about these supplements is done by the company, but some of it's not terrible. They're pretty expensive. If you're taking them, you need to if you get your thyroid tested, if you're taking biotin, that can impact your thyroid lab. So you just people need to know that. I haven't seen tons, like no one has been overjoyed with the results that they've gotten from supplements. But if you want to, the worst you're going to waste is money, right? So you can give it a try.
Fair.
So there's that. Collagen, no data to show that it helps with hair growth. Scalp massage, I think this one's funny. Scalp massage, 5 minutes twice a day, maybe a little improvement. Who's going to get us, like, I mean, I guess if you got into that habit, let's go for it. Not going to hurt anything.
Can I tell my husband I need one?
Yes, exactly. That's why I say people tell your partner that you need your twice daily scalp massage. What we do have a data for is minoxidil. So that was actually a blood pressure medication that during the trials they noticed that people had increased hair growth. So you can buy at like Costco, which is probably the cheapest, a topical minoxidil. It is super greasy. You have to put it on every night. It takes at least 6 months to notice an impact, but it does help. Okay. So there's that. Then there is off-label PO minoxidil, which does have some evidence behind. And so same thing, it's a that blood pressure medication. That the lowest dose we have available is 2.5. You can take half of that. Every day, and it promotes hair growth. So it promotes hair growth on your head and also on other parts of your body. And how dramatic that is on the other parts of your body is just going to be different. So some people just like, I got a few more hair plucks. Some people just like, they're like, I just don't like the way like I have more hair on my arms. So there's no magic pill for hair loss. That needs a prescription, but there's guidelines out about it now. So I think a lot of providers are happy to, let you give it a go and see how it works for you. So that promotes hair growth. If you're really like, if like this is something that is really concerning you, I do recommend seeing a dermatologist, because there are other medications that work with minoxidil that are just more complicated in terms of side effects and who can take them. And so you kind of like really need somebody who specializes in this, which would be a dermatologist, to walk you through that.
Team approach.
Yeah.
And so weight loss too. So, people like, so we know how estrogen is interplayed with insulin resistance and sensitivity, and kind of like cortisol and all of those things. We did the deep dive at the weight and strength workshop. Yeah. So if you guys want more specific information on that, I've got that workshop available in the membership. But like, so say, I feel like I hear people thinking, oh, I'm getting this belly fat and I can't get it to go away. What if I just take hormone therapy? Like, what will that fix it?
Yes. I wish I could say yes. Yeah. So what the research tells us, and I don't like this research, but don't shoot the messenger, is that is that metabolism doesn't change drastically in menopause, but it just is a slow decline over time. And it doesn't start till our 60s. But if you talk to anyone in kind of that perimenopausal, menopausal phase, they have noticed body changes and weight changes. So like you said, it does impact insulin resistance. And so that is kind of that belly fat. So even if you didn't notice a number go up on the scale, you're just going to notice like that, you just are holding on to weight maybe more in your middle. So estrogen does help with the weight distribution. Okay. So it doesn't help with weight loss, but many people do notice like, it's just like, I didn't notice a number on the scale, but I did notice kind of just this, it's not as like bothering me as much. Yeah. Okay. And some people are like, I lost 10 pounds. And I'm like, okay, like that's awesome. But probably what it was is that you're sleeping again. Like, all those things that we know estrogen does help for sure got better, and your brain feels better. Like you can have some forethought in what you're eating. So I think that helps a lot. And also with the insulin resistance, as estrogen is like an anti-inflammatory. So if a lot of your weight was just from like that inflammation, for some people it does help with that, and for some people they nothing changes. And so again, it's just you don't take hormones in hopes of weight loss, right. But if you notice that happens, then that's great. Yeah. Cool. Yeah, and I definitely listen there's plenty of other things that you can do. So yeah, definitely listen to that workshop.
Yep. Okay. How about sexual health? What should we be aware of?
Okay. So this is another big thing that people come to talk to me about, and I talked a little bit about it, and that is that it's so multifactorial. So it's really kind of two big things stand out for me. One is that libido piece, and like I said, you know, so many things are changing. Kind of, first of all, like spontaneous libido, that libido that just like comes out of nowhere and makes you feel sexy, that is driven by hormones. I mean, it's like we're animals, like we're being driven to mate when our in our reproductive years. So
Make us
when
take
that goes
action.
away, yeah, that just might not keep happening. For some people it does, for some people it doesn't. But
And for some people,
yeah,
it's never there.
it's not, yeah, they've never had
Spontaneous
spontaneous desire.
arousal,
Yeah,
just because you don't have that doesn't mean that there's a problem.
exactly.
Sometimes people just need their things,
Yeah,
right?
exactly. So people, you know, are noticing that and not liking it. And so the first thing I usually ask them is like, if you do kind of decide to engage in intimacy with a partner for a reason other than spontaneous desire, how does that go? And if it's like, oh, it's great, and I'm thinking like, I wonder why I never did this, you know, we don't do this more often, then like nothing is wrong. And my advice would be just to like learn about this new normal.
Keep exploring, get
Yeah,
curious.
yeah. And the great thing is like, this is another benefit of, you know, like I talked about, you're kind of no longer willing to put up with bad sex, or your, you know, your communication skills have probably gotten better at this point in life. So oftentimes people are even, you know, without, with things shifting, having more satisfying sex because they're able to advocate for themselves. They trust their partner more. They're not worried about pregnancy. You know, there's just a lot of good things that shift for sexual health. But that, you know, that kind of libido is something that you just need to learn to work with. And then another thing that happens for a lot of people is pain. And like we talked about before, no one's going to want sex that's painful. So oftentimes what that comes from is that genitourinary urinary syndrome of menopause. So all our tissues in our pelvis are fed by estrogen. There's our pelvis. And when we don't have that, our tissues, they, you know, this is something that I hesitate to describe it like this, but it's just biological fact, because it's kind of, you know, like it's a problem. Everything's breaking, but our tissue is getting very thin. It's not as supple. Like there are, if you look under a microscope, the skin is much different when it doesn't have estrogen. So this is one thing that I kind of am an evangelist about, is getting some estrogen into that tissue. So for some people, systemic hormone therapy is enough for that if that's their choice. But if you don't want systemic hormone therapy for many good reasons, or if you just, that's not really impacting kind of what your tissue is doing, local vaginal estrogen is the key. And you can get that from many different delivery systems. There is, you know, a cream, a ring. There are little tablets that you can put in there. For all of those things, I do recommend that people put some cream on their like clitoris and their labia as well, and kind of their introitus, if that's something that they feel comfortable doing. But this is something that I really think that most people should consider, because even if you're never going to have intercourse again, it can decrease your risk of urinary tract infections. It improves urinary incontinence. I was really kind of didn't believe it. How could that happen? But there are so many people who come back to my office and say, like, I'm not leaking anymore. My leaking is so much less now that I'm using this vaginal estrogen. And how long do you use it? You use it until you die. So that's the one thing I'm like, I kind of encourage everybody just to consider. Everything else is kind of, you know, based on what you're doing, but so much good evidence, safe for everyone, even if you've had an estrogen cancer or breast cancer. You know, I would always talk to somebody's oncologist, obviously, and just run that by them, but we have plenty of good data that sometimes we can send to your oncologist if they kind of haven't gotten the update, but I'm totally safe for everybody.
Yeah, so
Yeah.
that low dose, localized treatment is not going to be picked up
Yeah.
systemically through the bloodstream. So
Yeah.
it's going to treat those tissues, the vaginal tissues, and the pelvic fascial tissues and the pelvic floor muscles.
Exactly.
Yeah.
Exactly. One thing to know that sometimes I've found that puts people off from it is in the beginning you use it usually for 2 weeks, and it is every day for 2 weeks and then 2 to 3 times. So in the very beginning, sometimes people have systemic side effects like breast tenderness, and that's for 2 reasons. One, because you're using it every day for 2 weeks, and the other is because your tissue is so thin that it's just going like whoosh into the body. And so people sometimes are like, I don't know, like I had some breast tenderness, like this is not for me, and I'm just like, this is physiologically why this is happening. And sure, if that makes it a no for you, fine, but I want you to understand the physiology behind it before you get scared. Yeah.
And it really helps with, so there's non-hormonal vaginal moisturizers
Yes.
that can be very helpful, but also don't exactly treat the
Yes.
reason
Yeah.
why we have the decreased elasticity and the dryness. So the vaginal estrogen really helps to plump the tissues, and that's why we see a lot of benefit from the leaking, because around that urethra they're now getting a better seal, right? They have plumper tissues around it, they get better closure,
Okay, that's great.
and adds the hydration and that elasticity.
Okay.
So yeah,
Makes sense.
things can
Never
just
knew
work
that.
better.
Like I was
Yeah.
just like, really, is this going to work? And everyone's like, I'm not leaking anymore. Like,
Yeah. Because you think of the urethra as those muscles kind of close it like this. They don't
Cool.
squeeze around it, they
Yeah.
flatten it. And so if it doesn't have a good seal,
Cool.
it's just going to have a harder
Yeah.
time to work.
Awesome.
Yeah. And then, big piece of what I do is to then layer on, because especially if we've had discomfort or we've had stiffness in that area, the pelvic floor muscles and all the fascia around it are stiff and protective. So being able to then nourish the tissues and then also be able to balance the fascial and the musculoskeletal tensions that kind of responded to that. So always looking at the tissue irritability and integrity as well as the muscle and fascial tension and coordination piece of it.
So interesting. Yeah. See, you really do need a team. I wish there was one-stop shopping in menopause care, but there just isn't.
Yeah. And there's a lot, I also always ask if somebody comes to me and they say they're having painful intercourse, and I ask them if their partner has a full erection, because anybody, no matter what your tissues are like, anybody with like a semi-hard penis it's going to be uncomfortable. There's going to be tissue drag. So I had a woman come see me, and I did all the tests and stretch, and she had no pain. I could not provoke her pain. And then it turned out it was her partner, and so
interesting.
that was
See?
so I always
Learning
start
all
there.
the things today. That's so interesting.
Because
Yeah.
a lot of times, I mean, we are going through this. Our partners are having changes as well.
Yeah.
So
Exactly.
yeah.
Yeah. Yeah. It's just a whole new learning process.
Yeah.
Which is good.
Great. So, what are some of your favorite resources for menopause and sexual health?
Yeah, there is so much out there, and I think a lot of people are finding good access. 2 books that I have recently read that I kind of didn't read because I was like, I know a lot of this stuff, but then I read and my mind was kind of blown, are The Menopause Brain by Lisa Marsconi. She really talks about, first of all, it's just a good overview that is so evidence-based and very clear. About the menopause transition, but then she really talks about the brain changes, and it's just super fascinating and kind of makes you excited about what's going on in your brain and feeling like, oh, this is like a good thing. So love that book. And then
it kind of it gives like sense to it.
Yes, like
rather than like, oh no, I'm like failing. Like, oh,
Yes.
that makes sense. So now I can be okay with it.
Yes,
A little bit.
exactly. Like a lot of people ask me, like, why is this a biological, like, why did like Mother Nature invent this, right? And so it kind of goes back to those, like neurobiological roots of menopause and kind of like evolutionarily why this is happening, which just makes you feel better, or it did me. And then for sex, a book that I just kind of thought was maybe like, I just didn't read it because I thought it would be too basic, but really summarized everything, is Kelly Casperson is a urologist, and she wrote a book about sex that's called You Are Not Broken. And it just like really summarizes how women are, people who are born as women in female bodies who are kind of acculturated to sex, and all humans really, what they learn about sex, and that we don't get good sex ed, and kind of that idea about if you're not having satisfying sex, like why are you going to keep having sex, and just like really breaks it down into the basics, how you can talk to your partner better, really like how to get from where you are to where you want to be, for like the average person. Who's kind of culturalized in this soup of like what sex is supposed to be. So and it's really easy to read, and also you could listen to the audiobook because it's fun. She reads it, but yeah, love that book. Yeah.
Awesome.
Yeah.
And like, how can people work with you?
Yeah, so I I have a private menopause practice with my colleague Vanessa. We're based out of Massachusetts, so I have a license in Massachusetts. You can look us up at westernmassmenopause.com. I do have an office. We have 2 offices where anyone from anywhere can see us, outside of Massachusetts and inside of Massachusetts if they want a in-person appointment, one in Great Barrington and one in Florence, Mass. And also soon we'll be having some group care for folks. So you can join our mailing list by going to our website, and we can go from there.
Awesome.
Yeah.
And so what would group care look like?
Yeah, so it won't be medical care. It's more going to be like a coaching, because like we talked about, kind of the menopausal hormone therapy and kind of the supports you put in place are one thing, but really the key is mindset. And so kind of how can we change our mindset and make decisions that really promote our health and make us feel good about this transition, kind of rather than being pulled into kind of the cultural conversation that's kind of promoting that this is like a chaotic, terrible time and you're going to feel bad.
Yeah, gloom and doom.
Yeah, no. So like what can we get out of this transition that's going to be positive and kind of set us up for a fabulous last half to third part of our life.
Okay, and would this be in person, online?
It's online.
Okay.
Yeah, so online.
Okay,
Yeah.
so and similar, so that sounds like a great complementary service to like my membership, where again, getting the information out there,
Yeah.
being able to have group Q&A and case reviews and just have that
Exactly.
dialogue, because a lot of times, if someone has a question, most people are gonna in the group are gonna
Yes.
benefit from it.
Yeah.
And being able to like have the different perspectives from medical professional, pelvic health, and being able to like blend those. So love to be able to like help share information,
Yes.
and
Yeah.
we're going to be putting this in the membership, and so exciting
Yeah,
stuff that we
great.
have.
Yeah.
We have a lot to offer for in when it's in a setting like this, we can reach further out,
Exactly.
right? So we're not
Yeah.
limited to can you drive here, do you have to be in this state, those kinds of things.
Yep. Yep. And this work is really best done, I think, in community with other women. So, it's one thing to have a one-on-one appointment, but you really need like your village and your people who can support you.
Yeah. And also, the other members of the group are
Yes.
such a great like participant and
Right.
contributor,
Exactly.
right? So as we're having conversations, people will have their own experiences and can bring that and then lead them to different questions. So,
Yes. Yeah. So much support out there. I think it's great.
Okay.
Yeah.
Any parting words or anything else that I
think not
missed?
much. Yeah, this has been super fun. And I think my big message is that, it can feel scary, it can feel chaotic, but there's hope on the other side. And, it's actually the brain changes, or kind of understanding the brain changes, is what really kind of got me excited about kind of this next phase of my life. And, most people, when they're through the chaotic perimenopause phase, really do feel a new kind of fabulous. So
Awesome. Thank you. So we will be seeing more of you. We've got the Menopause Menopausitivity Facebook group that is just
Yes.
open. You've got your, people can see you in person
Yeah.
privately.
Yeah.
People can see you in the membership
Yeah.
format, group
Yeah.
format.
Yeah.
So
We also do
awesome.
telehealth, telehealth for, you have to live in the state of Massachusetts to do telehealth just because of, like state laws, but lots of ways to get in touch.
Awesome. Thank you.
Yeah. Yay!